Hello, everyone. Can you hear me? Pablo, can you hear me?
Yes, I can hear you. Can you hear me?
Yes.
Okay.
Hello, everyone. Welcome to the CTS webinar on Waveform. I am Dr. Shazia Jamil. Some of you may know me from CTS and also CSRC, as I've been a speaker with CSRC. I'm the education chair for California Thoracic Society for the last 10 years. And I am the co-host with Pablo Gonzalez, who I'm going to introduce right now for this CTS webinar that we have created. So Pablo and I both work at Scripps. I'm professor of medicine at Scripps Clinic. My background is pulmonary, critical care, and sleep, and I practice all three specialty. I'm also professor of medicine at UCSD Medical School, where I teach pulmonary. With that said, Pablo and I have worked for many years at Scripps. Pablo is truly an outstanding respiratory therapist, educator. He is currently staff at Scripps Health, and he has worked at multiple facilities within Scripps. He is a clinical specialist who's involved with California Thoracic Society, Planning Committee, and California Society of Respiratory Care, introducing also with me our third Advanced Mechanical Ventilation Symposium that we have created, which would happen this year on June 28th. And Pablo and I are very, very interested in mechanical ventilation. We're very interested in trying to understand the interface between mechanical ventilation and the patient, because we both really are passionate about patient care, especially in the ICU and lungs. Pablo, in addition to me, I'm primarily adult, but Pablo is definitely much more subspecialized because he has expertise and education and training in pediatric and neonatal respiratory care. He's also an ECMO specialist. He has been educated and trained at Mayo Clinic, Rochester, and he has worked with Dr. John Marini, Dr. Gustavo Cortes Puentes. Many of you may know them from extensive literature that these researchers in lung mechanics have produced. And they were at, Mayo Clinic. In addition, Pablo is now very, very interested and very involved in mechanical ventilation and understanding how the interface between patients, especially when they're intubated, during non-invasive as well as mechanical ventilation. With that, I'm going to have Pablo actually present because I think he will do an excellent job. And we have both created this PowerPoint. And Pablo, with that, I would also like to say in ahead of time that if you are interested, please attend the California Society of Respiratory Care annual meeting, which is going to happen from March 11th to 13th, and the CTS conference that we have annually in Monterey, California, which will also happen in March 18th to 20th in the beautiful Monterey. So thank you. With that, Pablo, thank you so very much. I am willing to learn and learn more today with you. And just few other things, it would be better if attendees have questions, please write it in a Q&A or a chat box. We will take every question, I promise. And something that we would not be able to take at the end of the session, we will get back to you because we will know who asked that question. Thank you, Pablo.
Thank you, Dr. Jamil, for the introduction. Hello, everyone. I want to say thank you to California Thoracic Society and California Society of Respiratory Care that had done this venture. So um, I'm here to present mechanical ventilator waveforms, the interpretation and troubleshooting, a case-based approach. Actually, this picture here that's at the front of the presentation is kind of what triggered me back to revisit the ventilator waveforms. This was during the pandemic. Let's see. Have no disclosures. The learning objectives will be equation of motion and mechanical ventilation, understanding waveform scalars, and the ventilator waveform analysis and a scenario at the end. Uh, Personalized and precise management is what helps the patient when managing a mechanical ventilator. And it's something that it's required for patients who are unable to achieve that balance in the pH and have that proper gas exchange. The ventilator settings must be adapted to suit the patient's need for oxygenation and CO2 elimination. And that is just in the simplicity of it. Every ventilator around the world, as you know, there's many of them and there's many modes. Use the equation of motion, where P vent is a peak pressure on the ventilator, the CRS, which is part of the elastic load, respiratory static compliance. V stands for volume, R stands for the resistance, and V is for flow. There's usually a dot on the top. And as you know, our static compliance is the reciprocal of your elastance. So in the US, we mostly use the CRS. In Canada or in Europe, they might use the ERS. Now, this is the basis of all ventilator modes and the mechanism of action. If you understand the equation of motion well, managing ventilators, variables and data of ventilators become much easier to understand. Okay. One thing we have to keep in mind that is everyone's lungs is different size and depending on the lung disease process of that patient. There has been extensive research out there in regards to patient ventilator asynchrony and the standard waveforms that sometimes when we look at these ventilator waveforms, they might look normal, but in reality, they might be deceiving. One of the things that always does help is measuring the respiratory static compliance, and what that really is a representation of is of the alveoli pressure. As we all know, we want to protect the lungs. We want to monitor your plateau pressures, and we also want to monitor your intrinsic PEEP, also known as auto PEEP. As we know here, the static compliance is equal due to the volume that you exhaled, and you divide that by the plateau pressure minus your total PEEP, which will equal your respiratory static compliance. Now, this is an actual patient who was a severe status asthmaticus. It was on volume control mode, and we ended up changing to a pressure control, which was a PRVC, an adaptive mode. And this particular volume control mode, we checked the plateau pressure. We had the peak inspiratory pressure. We ended up checking for your driving pressure, P drive. Usually you want that to be less than 15. And we also monitor your respiratory static compliance, something that is different when you actually are in training extra pressure in the lungs, the auto PEEP. So as one example here we have is a plateau of 41 and minus a total PEEP of 31. The driving pressure is a difference of that, which is 10. So depending on the total volume that you do have, let's say 400, divide that by your driving pressure of 10, your static compliance will be 40. Now, this is something that I closely monitor because depending on my settings, if I see a trend going down or upwards, I know if I'm making the right decision regarding that setting. Here's a picture of how I collected for the auto PEEP. You can see on the left side, you have a plateau pressure and you have an expiratory maneuver done. So you get my total PEEP 21. Now the respiratory static compliance, increased static lung compliance, especially on the neonatal is sometimes you have lung surfactant that will help. stabilize the resistance and decrease the work of breathing from the patient. Lung volume compliance is at its highest at FRC. Your posture, supine, upright. You have all these things that can hinder the static lung compliance, right? So like loss of surfactant, the decreased lung elasticity, pulmonary fibrosis, fluid, pneumonia, and we can go on. But it's something definitely to keep in mind and the reasons why we have to measure as well, leading to the dynamic compliance, especially when patients are prone, uh, for us as clinicians, sometimes we might overlook and underestimate these parameters, but they can actually make a big difference when it comes to managing the ventilator. Now, calculating the dynamic compliance is a little bit different compared to your static compliance. It looks very similar, but it's basically the exhale tidal volume divided by the peak inspiratory pressure minus the total peak. Now, these are really important because of airway resistance and the increased airway flow. Now, calculating the airway resistance here is your peak inspiratory pressure minus your plateau divided by your flow. It's a lot of calculations. I still like to do them by hand so I don't forget. I know sometimes some of the ventilators, I don't really trust the airway resistance that is displayed, especially when you have intrinsic PEEP. But here's an example where the tidal volume is 500, the peak inspiratory pressure is 89, the inspiratory flow rate was 87, and that's over 1 liter per second, and my plateau is 40. So the question would be, what is the airway resistance? So in this instance, I go on through the calculation process, and it was 33.8. So it was very, very high. You have the normal display below, but also the severity level on the right. But as I look into the ventilator waveform, you can see that I'm pointing out at the peak inspiratory pressure, which is, obvious is super high. But at the exhalation part of the flow, you can see a rebound as it's exhaling, and that is an indication of small airway collapse. Now, chest wall compliance, some of the things that could cause a decrease in chest wall compliance are listed on the left. Some things that are very common is pregnancy, obesity, abdominal compartment syndrome, or even prone position, right? Now, on the right side, you can have an increase in chest wall compliance, such as someone got rib fractures, then they had to do a rib resection, or they had the open chest. So we kind of got to see a little bit of understanding of peak inspiratory pressures, the airway resistance, the dynamic, the static. Now I'm kind of focusing into the cycling of a breath, as you see, is either patient or machine triggered. We take into account the inspiratory part, which is this slope here, and then we look into the cycling when the inspiratory phase is terminated, and as it goes into the expiratory, which is depending on the PEEP set. There are 4 types of triggers, and the basic ones are just pressure trigger, flow trigger, time trigger, or the neuro trigger. One thing to note here, the neuro trigger, I highlighted it in green, but you can see as the patient pulls, they will pull from your pressure time waveform. There are 4 types of cycling as well: volume cycling, flow cycling, time cycling, and pressure cycling. These are just when a ventilator's inspiratory phase is basically terminated in simplicity. Now, regarding the double triggering and flow starvation that was studied at Mayo Clinic and they published in 2019, they found that it was very frequent in regards to when it came to a mode volume control versus pressure control. One, you have a set flow versus one, you have a variable pressure. And as some research has come out, some patients, when there is patient muscle effort on a volume control mode, you tend to have a little bit more asynchrony or desynchrony. Now, regarding rapid ventilator waveform analysis, one thing I always ask, are the ventilator settings safe? What are the things that I'm looking at or ask is, what is the goal? Is there a kink in the ET tube? Any secretions? Is there water condensation, bronchodilators? Is there a reversal of the mucosal edema? What about the expiratory filter? Is it brand new, or is it congested with all these medications that you've been giving to your patients? In some places you don't have a heater, so is it the HME filter? Some other things that I will ask are, my ventilators, are they in the safe parameters regarding, tunnel volume 4 to 8 cc's per kilo, maintaining my plateau pressures less than 30 and my driving pressures less than 15. Now, measuring the intrinsic PEEP, doing the expiratory flow maneuver, as well as my IE ratio, my I time, my FiO2. Now, all these are a lot of parameters, especially when you get to these more advanced modes and use other respiratory tools. But one of the things that we want to maintain is, identify the mode, the trigger, the limit, the cycle. Is the patient comfortable? Is their ventilator asynchrony, or is there synchrony? Is it trigger, work shift, or cycle? Some of this we'll be addressing later on into another conference, but it goes more in depth. And I think that's why I still love doing what I do as a respiratory therapist, is because respiratory is very complex. One of the things that I started emphasizing a lot, and I don't know, many of you probably seen it in the respiratory community, is addressing the P0.1, which is a reflection of the work of breathing of the patient. P0.1 has been studied in the 90s, and I believe in 2017, I had one case that really made me pay attention to the P0.1. So it's an occlusion pressure at 100 milliseconds at the start of a breath. And as you can see on the pressure time waveform here, is when it occludes. It basically does like a negative inspiratory force occlusion just for 100 milliseconds. And usually you have to put this on a pressure trigger, and you will find that is an indication of either increased work of breathing, or there's no increased work of breathing. But then the research on this is that each ventilator has its own algorithm, so that is still being studied. Which ventilator, can you associate this to? But if you have a P0.1 of 9, that is very high. Most likely you need to sedate, increase P, change the mode. Those are things that you will have to troubleshoot. Okay, so these are kind of like the parameters to look at. Regarding the auto PEEP, this is a very, it comes from the 1989 from Dr. Tobin regarding the intrinsic PEEP, the waterfall effect, right? So there's still extensive literature out there, but then at the same time, there's the pros and cons in regards to, if you do match, your set PEEP to your auto PEEP, and eventually we'll do another part series in regards to this. But definitely, in simple terms, if you have a set PEEP of 5 and you have an auto PEEP of of 5, so a total PEEP of 10, you can match your uh, total PEEP at the 70-80% per liter literature, but sometimes what you might see if you have a line that is measuring your blood pressure is if you go from PEEP of 5 to PEEP of 8 and your blood pressure decreases, that patient will probably not benefit from matching that 80 percentile of your total PEEP. So there's some cases where, physicians or RTs do make that clinical decision. They drop the PEEP to 0. There's controversy in regards to that as well, but at the end of the day is helping in managing the eye time is my belief in regards to this. Here's an example of eye time. When it's excessive and when it's appropriate eye time. On the left side, you have an excessive plateau here, and there is flow held at 0 with a 0.6. And in this example, you have an appropriate plateau with an appropriate eye time of 0.35. And as we go into the right side here, it's an insufficient flow and the eye time to fill in the lungs. So I've seen this multiple times. This is mostly like a NICU, but it also pertains to adults or pediatrics. Now, regarding the waveform scalars with patient muscle effort and pressure, volume, flow, this is kind of what it looks on the left-hand side, a patient trigger flow trigger. As you can see, the flow here, the white dot, is triggering the pressure. And as we look on the right side, there is just machine triggered. So now look at the shape of the expiratory flow pattern here. And this is the normal resistance on the peak expiratory flow rate. And as you can see, the peak inspiratory flow rate. As we look into the pressure support CPAP here, patient trigger is, you can note that it's a white little dot here. That means that it's flow triggered. And also the the flow time is being triggered here as well. Now, there is patient muscle effort on the peak inspiratory flow here, as you can see, versus this one. It's a little bit more concaved. And the shape of the peak expiratory flow rate is something I look into when it comes to lung compliance. And also, as you can see, my pressure time on the inspiratory end, and then on the peak inspiratory of the flow rate, right? So these are like just normal resistance on this patient. There's no resistance issues. There you have the volume versus the pressure here. And look at what I'm referring to is you have the image on the left. You have a small airway collapse, and this is a sign of high intrinsic PEEP. And look at the one on the right. Look at your peak expiratory flow. Very different, right? And what about patient muscle effort? Now, I really love this because you get to see the difference in flow patterns, especially on the inspiratory, peak inspiratory flow rates. So A kind of shows patient inspiratory muscle effort. B, there's a compensation due to the work shifting, basically flow starvation, but you also, I'm looking at the flow in liters per minute, which is up at 100. Now C is excess patient muscle effort on the peak inspiratory flow rate. So you can see how much the patient actually is working against the ventilator, either as flow starvation, or the PEEP might not be set appropriately, or is having a metabolic issue. These are things that we have to put together as clinicians. Now, D is a little bit more of a normal peak inspiratory flow rate, but insufficient I time. It's not reaching all down to the baseline. E, you have a mild patient inspiratory muscle effort and the peak inspiratory flow rate, which is also observed in these two images. Now, I'm going to look into the expiratory side of the flow pattern. You have A as a little bit more of a normal side. We're not addressing the inspiratory, but then we have B. Look at B, severe restrictive and intrinsic PEEP. This patient had, I believe, a total PEEP of in the 50s, which is super high, severe status asthmaticus. The ventilator was almost reaching at 300 liters per minute. Little clue signs that the ventilator does that sometimes we might just overlook. At the same time, C, it shows some severe restrictive, but not as severe as B, and not as severe as the letter D here with the excessive intrinsic PEEP. You can also cause intrinsic PEEP if the patient is having high, muscle effort or work shifting or flow starvation. The patients can actually fight the vent, creating their own auto PEEP, and then eventually not tolerating the ventilator and requiring sedation. I've seen that a big majority of my career. Here's another example of how the expiratory flow pattern behaves. A is a sign of overdistension. This is actual like a APRV patient. B, we have a patient muscle effort in the peak inspiratory phase, but also an ineffective effort or missed effort on the exhalation part. Let's just note it here. In C, we have a severe ARDS patient on ECMO, collapsed lung, as you can see on the expiratory side, but also there's a leak from a trach. So very narrow, the lungs are almost whited out, and in this case, it's just a leakage over here that's going above and whitening that flow pattern. But as we look into a D, it's a little bit more of a normal decelerating pattern on the exhalation part when it comes to APRV. And E is just a dynamic airway collapse. This patient actually needed a PEEP of 20, high BMI. It was only on a PEEP of 5. And as I mentioned earlier, sometimes the shape of it can also remind us of that it's not abnormal. For all NICU therapists or pediatrics specialists, I put this on at last minute just to kind of emphasize the flow sensor, especially on this ventilator or on ventilators that don't promote flow sensors. When you're managing infants at, let's say, 800 grams, 300 or 600 grams, and their total volume should be in the 5 mLs, 6 mLs, so 4 to 6 cc's per kilo. When you don't have a sensor and the sensors are on the exhalation side, actually they could be very damaging to the patient's lung, creating intrinsic PEEP, leading to pulmonary interstitial emphysema, kind of like those COPD patients that end up requiring the oscillator. I know eventually become bronchopulmonary dysplasia patients, but these some of multiple cases that I ended up seeing, and it required a lot of conversation with other people that I've known, and it led to us to start using the flow sensors with the little extremely low birth weight babies. Now, this is a question to all. Is what are the oscillations? Are these from? Is it A, aerobica, B, IPV, C, is it from the vest, or D, is it manual chest percussion therapy? I'll give like 1 minute. Okay. So this is letter B. Now I wanted to show this waveform here. This patient's on a PRVC mode, which is a pressure control CMB, but adaptive, right? It adapts if there's patient muscle effort. And like I mentioned at the beginning of this meeting, is that picture that was displayed really took me off surprise, and there's been a lot of talk about it in the community on respiratory in regards to this type of mode, that the ventilators do not know how to recognize if you are having severe ARDS, or you're having increased work of breathing. It just thinks that you are having good breathing and that you're ready to come off the ventilator. So the ventilator basically starts taking pressure, so the support away from it, the mechanical part, and lets you do all of the work. Well, it's kind of like, you're trying to control this patient's disease process and be lung protective, and you're trying to wean them off, and you put them on this PRVC mode, and not realizing that you might risk of having a ventilator-induced lung injury, because you can have them do patient self-inflicted lung injury. As you can see on the expiratory side, is bulging out, basically hyperinflating themselves, creating their own auto PEEP. As you can see on the pressure, where we were talking about the occlusion pressure at 100 milliseconds, is pulling extensively. And also the PEEP is bulging upwards. So in regards to this, it's like the patient had low platelets, blood thinners were put on hold. There was red frothy thin secretions indicating for alveolar hemorrhage for the past 2 days. And the chest X-ray was actually, worsening bilaterally. So what interventions would you choose? You have all these that could apply here. You have your pressure support CPAP. Do you maintain the PEEP that you have, which is PEEP of 12? Do you add TXA? Do you change to a pressure control CMB, which is just set? It's not the A, which is PRVC. Do you sedate and paralyze? Or what would you recommend? Feel free to type it in. I'll give 1 minute. And like I said, you can put select all the apply. Now, from before to post, look at the flow pattern of the waveform and the pressure time, but also at the peak inspiratory pressure. You can look at your P mean, the respiratory rates, the tidal volumes, the cc's per kilo, and look at what we did. So a pressure of almost 30 over PEEP of 12. This patient was on 50%, then we dropped down to 40%. But the cc's per kilo are still 7, so in a good safe zone. The respirations came down to 26 versus, earlier you were at 32. And you have a better looking pressure time waveform, and you have a better looking flow pattern on the inspiratory and expiratory phase. Now, as you can see before, the patient was air hunger, right? Flow starvation, work shifting. So the support wasn't there. It was a high respiratory drive. And now the goal is just to keep it simple. Either you're on volume control, you're on pressure control, or you're on pressure support CPAP. And at the end of the day, you can also choose your PRVC or your volume control autoflow or your CMB, APV, CMB, all these other modes that are adaptive. But, make sure that you recognize and you look at these ventilator waveforms and you familiarize yourself with what is normal and what is abnormal, and then start to troubleshoot. There's over 200 and something modes. In simple terms, just keep it simple, basic, and traditional modes sometimes are just better. This patient ended up just being on pressure control CMBS, a set, TXA, and very minimal sedation. So, my goal is to always minimize sedation and prevent, patient self-inflicted lung injury or VILI. This one, I just started learning, paying attention to it over a year ago. And as you know here, this is a patient with an inspiratory I time of 0.9 on the top left screen. You can see the inspiratory flow rate, it never reaches down to the baseline. And as you see the progression, I ended up having an I time of 1.75 on this patient. If I was concerned about this, it would be the waveform delayed cycle, which would you see a bulging upwards towards the pressure time waveform at the end of inspiration, where the patient's effort and the ventilator collide, actually risking the patient to cause a lung injury. But in this case, there's no signs of that. But as I had my end-tidal CO2 waveform from A to B to C, you can see the difference in the shape of it. So I just started paying attention to the end-tidal CO2 and see if it correlated with my I time. So I've never seen this until just like a year and a half ago. And to my surprise, look at the difference in tidal volume, how it affects your CO2. Probably you have a lot more blowing off and a lot more diffusion that is passing through the membranes, right? So that is a little interesting thing that I liked. Here you have volume control. It says AC volume control, but then as you can see, there's autoflow and there's some automatic tube compensation on this ventilator. So is this a volume control or a pressure control mode family? And what's with the PEEP? So the PEEP keeps deflecting down. So this patient is actually on 100% FiO2, 450 of tidal volume set, which is 6.1 cc's per kilo. I time set at 1. The respiratory rate is set at 22. The PEEP is set at 12. So this patient's very sick. So my question when I came to the bedside is on the exhalation part, what's going on? It's something that I wasn't aware. And to find out, this ventilator behind the scenes has an expiratory compensation. Why would that be on? Mostly if it's like like CPAP, but C-flex, kind of like to make it more comfortable for you on exhalation. It's kind of like a setting that you'd use maybe for home sleep, patients. But why would that option be in a patient that it's in an intensive care unit, and why would it be turned on? So we turn that off, and basically we start losing our PEEP effect. So with that, if anybody has questions, uh, feel free to chime in. Let's see. Um, Many people are asking, will the PowerPoint presentation be available for download? Um, yeah, I'm willing to share. I think it'll be displayed on the California Thoracic Society. Um, and I think it's also being recorded. So
Thank you, Pablo. Every time you give a presentation, everyone learns, and I definitely learned today. One of the attendees had asked in the Q&A about proning and lung compliance, and I did send a Marini article citation, and maybe you would like to comment on it. That proning, it really depends on the surgical patient in my experience, spine surgery, other surgery versus medical patient and ARDS patient. But in our medical patient and ARDS, I have seen remarkable results in improving lung compliance with proning for very simple reasons. Obviously, you're trying to restrict. When you prone patient, you're trying to have the abdominal restriction, the sternal restriction, and then you're taking away the heart weight. Even a normal heart rate can cause left lower lobe, basilar, atelectasis, especially if they're supine for days and days and weeks and months, sometimes in the ICU. And it is true that the dorsal part and our lower lungs, which 2/3 of the lower lungs are posterior and lateral, they do expand better on proning. But as a respiratory therapist, I would like you to comment on what I just said, and especially because our attendee did have that question in your experience.
Yeah, so proning is definitely, we do that with the infants, and with the infants, it's very very effective, right? So I know Gattinoni and Marini, and Gustavo and many others that I follow is they're all for proning. You have the dependent and the non-dependent, right? The non-dependent being the front part of the chest, and um, the the non-dependent is the front part, and the non-dependent's in the back. So the non-dependent, when you do prone them, that's when that's when you tend to find that equilibrium and balance. Now, biggest part of the lungs, right? So more, and also is the lungs that tend to get injured the fastest, but that don't get utilized. Now, if we look into Mayo Clinic has a really good protocol in regards to hypoxemia, and what they do is they, you know, intubate patients, and obviously like in 30 minutes, you start assessing the plateaus, the autopeeps, all these parameters. And if the patient's a candidate for proning, then definitely prone them. So the sooner, the better. Many people have also, like I see on the chat, talk about APRV and ARDS. If you know how to use APRV, definitely go ahead and you're comfortable with it. Use it. It's a pressure control family, and it's a IMV. But majority of the times, what I find from clinicians that have been doing it for, years, is that there's always parameters that they miss, and it leads to hyperinflation. And when it leads to hyperinflation, you're creating more intrinsic PEEP. And when you add more intrinsic PEEP, the diffusion and passing of oxygen, CO2 aren't there no more, which leads to hypotension, pneumos, and etc. So I find that APRV is very tedious in regards to work and when it comes to the knowledge part. So you have to have a really good clinical educator that will spend the time and quiz the RTs and physicians, and to really make sure that people know that mode. I'm all for it. I love APRV. Actually, we used APRV on ECMO patients, and we had an RT that actually saved his life. And so if you know the mode, go for it. But proning, definitely go ahead and prone your patients, especially on those hypoxic patients, if they're a candidate for it.
Pablo, there was a question much earlier on which asked that these equations, is it okay to use apps to calculate these equations rather than hand calculation? Have you had experience with certain apps?
Yes. So you know, there's a Society of Mechanical Ventilation. They have extensive, it's a app that, or a website that I follow. Um, I tend to do the numbers in my head or in my phone majority of the times, or we built it in Epic where you just enter the numbers and the Epic does it by itself. Epic is just a computer system in the electrical medical record that we use here. So I think always double check the equation as well. So you know and then if you feel like you trust it, go for it.
In regards to APRV and ARDS, you have pretty good experience. I know that even some physicians are not very comfortable because we don't use APRV all the time. So we have to have the comfort level, we have to have the education and training. And if you only do APRV once a year, it's not gonna, be helpful, isn't it? Just like anything else in life and in practice. So how did you learn APRV? I know that you're very, very good. You and I had shared patients that only you could help us as RT, and some other RTs were not very comfortable. So did you learn it at Mayo Clinic? How do you educate other RTs and RT students that we also have in our ICUs?
I was at Regents Hospital back, I think, in 2015, where John J. Marini was at. He had very good RTs there. And some were introduced me to APRV, especially it was a burn trauma center as well. They used it, but I felt like I wasn't getting the enough um, details in regards to parameters and settings. So I actually took the time and the money of my own and just went to Syracuse University, and there was Dr. Habashi there with his team, and Maria Maiden was there, and Penny and Gary, and I spent some couple days there and just geeking out on APRV, and came back at that time. I think I was at Mayo Clinic, and we had a ectopic cordis, a pediatric patient who actually wasn't responding, and we put that patient in APRV, prevented that patient from going on ECMO. Um, and ever since then, I just started using it and understanding it. And now I feel very comfortable in managing APRV and when not to use it and when to use it, you know. Sometimes you might have the best settings and unfortunately it doesn't work for that patient. So sometimes there's no ventilator mode that will fix, you know, the disease process of that patient. So sometimes if they're an ECMO, candidate for ECMO, then we might end up switching to the ECMO um, phase. So just recognizing when is appropriate and when not.
There's a question, if you could explain to the attendees exactly what do you believe is the difference between the PRVC and APRV? So perhaps it's a good idea. We all know how to set PRVC as physician's orders or RTs make an order, but what exact order? I think that's always a confusion, the T high, the T low. What exact order would you like physicians to put in or the RTs to put in? So let's talk about that.
Yeah, this is really interesting because I think it's going to be part of one of our series later on. So um, I see some people asking about APRV, and many RT clinicians and physicians around the US and the world ask about this mode. I'm going to leave it to simple part. And what I'm working on with my staff is what is your plateau pressure and what is your total PEEP? So if you do the inspiratory hold, you will find the alveolar pressure. That will be your P high. You know, will there be any risk of barrel volume trauma if you go, you know, below or if you sustain at that level? Not not momentarily because that patient probably has been for 1 or 2 days, 3 days with that plateau pressure, right? If you confirm it. Now, start at your plateau pressure. That's going to be your P high, and your P lows are always going to be zero. And your Your T low is going to be 0.5 seconds, and your T high, you will adjust based on the release rate. So if you had a respiratory rate of 30, then set your T high to release at a rate of 30. There is some calculation you can do, but now the ventilators, you can do it, so you save some time. Um, the next phase is you start the ventilator with that patient, and then you have to do save the waveform and find the peak expiratory flow rate 1, peak expiratory flow rate 2, and have to do a calculation to find an optimal recruitment level for that patient. And based on the plateau and the expiratory hold maneuver, you will find your driving pressure. So if my plateau is 25 and my auto peep is total of 15 because I set it to entrain purposely, that will be your driving pressure. So if you have a tidal volume release of 500, you divide that by 10, and that will give you your static compliance of 50. So see, it's a lot more complicated, but I think in the coming months we'll work on APRV, and I think it will be a really good a series for many people to understand APRV TCAF method. And this is what I'm talking about when Dr. Habashi trained. When I went and trained with them, was the APRV TCAF method. So.
No, thank you. It gives us at least a kind of a basic understanding. And again, I cannot stress enough that bedside is very important. When we make any changes in the ventilator, we don't just do it and then leave and have nurse calls us. We have to be at the bedside for several minutes, at least 10, 15 minutes, and especially with APRV, and do all these calculations and try to see what the patient is, experiencing. With that, I do want to make sure that we also answer one of the questions. Perhaps you can go back to your PEFR, the peak expiratory flow rate slide. The question is it correct that E is a dynamic airway collapse and D is normal? Maybe you can explain a little bit.
Is it this one or?
Let's see.
I think this, is it this
Yeah,
one? Oh, peak expiratory flow rate?
yeah, PEFR.
Mm,
Yeah, D was normal. So you go back.
Oh, this was more on the APRV.
Yeah, and E is dynamic airway collapse.
Correct. Yeah, this patient had a BMI of maybe in the 40s with a PEEP of 5, a PEEP of 20 actually this patient needed. And then if some of you are asking about APRV, right? So A and D, A is a hyperinflation. This is where you have to extend your T low. So if your T low is 0.5, decrease by 10% of that. So, do 0.55 or, it, but it gets very complicated. I think eventually in the coming months, we'll end up doing maybe series part 4 on APRV. But as you can see, D is more decelerating. You have this little slope. So.
And I do want to give another opportunity. I do not know if we have answered that question, but one attendee asked, please comment on very low body weight infants and ventilator strategies, which I think you touched upon, that with very low infants, I think you said 4 to 5 ml, but could you please touch upon that?
Yes, 4 to 6 mLs per kilogram, as those neonatologists or NICU pediatric specialists, RTs or clinicians know. I'm. Are you guys able to see this screen? Um, let's see. It kind of shows here the 2 mLs, the 3 mLs, maybe 3.8 to 6.4, maybe 5 mL. So. These are all in a pretty good safe mode, except the top right, you're like at 8.5, but this patient was ended up going to oscillator and surfactant and all that. But um, in these cases, we need a flow sensor for these kids, so extremely low birth weight babies. And that's what I wanted to emphasize. But as you can see on the waveform here, you have a flow trigger with a pressure trigger, a flow with a pressure, a flow with a pressure, and then all of a sudden you have a flow but no pressure. And then that extra flow and that it's also generating extra volume. So there was a whole discussion about missed pressure, but actually giving volume and flow. Was it the circuit, which it was not the circuit? Was it something with the valve on the exhalation part? It was not that. Was it defective equipment? It was not defective equipment. Was it the internal expiratory flow sensor inside? It was not that. Once we added the flow sensor, all that extra noise and missed triggers started going away, and then we stopped seeing these kids being transitioned to oscillator, ventilator, I&O, and then, leading to poor outcomes. I don't know if that answers that question.
And perhaps in the future, we can have a webinar primarily for pediatric and infant mechanical ventilation if there's an interest. I think that's an extremely important topic and so much different than adults. The disease patterns are so different. And we're very fortunate, Pablo, that you have education and training with all age ranges. So I think that would be a good idea.
I posted my email here. Some people are asking for what is it called? Basic waveform for students.
Webinar, yes.
Yeah, I think the webinar the CTS will display on their website, right? Is that correct?
Yes, yes. We will record it, and to the attendees and registrants will make every effort. On the other hand, would you like to emphasize the Google Doc, the different waveforms and the quiz, because it makes us think when we are taking a quiz, and it's again to improve knowledge base. And would you like to emphasize that perhaps the attendees can do that? And
Yes, very good. I wanted to just get a personal, data and collect data and see the knowledge that people have before this presentation, and hopefully in the next series you learn something and how to interpret ventilator waveforms. So we'll do a pre-test and we'll do a post test, and that will help me to understand and see where I can improve. Any feedback, I always appreciate it. But I definitely want to make sure that attendees are actually understanding this complex information.
And one of the attendees does say that the quiz was very helpful. So thank you for that attendee. One more question, if you don't mind, Pablo. Would the higher airway pressure of APRV overinflate the lungs?
So if you are on 30, if you are on 30 over 5, or 30 over 0, let's say, but you have your T low to 0.5, you're purposely entraining some auto peep. The question is, how much of auto peep are you entraining? This is where it gets a little complicated, because if you have a ventilator like, let's say, Puritan Bennett, I don't I don't know. It's been a long time I've worked with Puritan Bennett, but can you do an expiratory whole maneuver to measure your intrinsic peak? If you use the Gettinger servos, you can actually do an expiratory maneuver. If you use the Dragers, they have an expiratory maneuver, but you run at risk of maybe having too extended of a T low, too extended of an exhalation that possibly can de-recruit that patient. Um, but with that, 30 over 0 seems like a driving pressure of 30, right? So some of you might think it's excessive. But what if you have a T low of 0.5 and have an optimal setting, but you're in training maybe a total PEEP of 15. So then the difference is actually a driving pressure of 15. So that's why it's so important. I've seen patients have a driving pressure of 20 or 25, and this is where science and comes in and leaves us with more questions. Why are they improving? Literature says that less than 15 or 17 is supposed to be the best, but for some reason these patients actually improve and walk out of the hospital, right? So sometimes you just have to try. So yeah, there's no super clear answer with APRV.
I would like to thank Pablo, and I am so truly fortunate to be working with him side by side in the ICU as an ICU physician. I think it's extremely important for all physicians, whether pulmonologists, sleep doctors, ICU, which I'm all three of them, to work really closely with our respiratory therapists. One of my major objectives as chair of California Thoracic Society has been over the last several years to have more presence of our respiratory therapists in our conferences, to have them speak at our conferences, in our hands-on session, to be participating, and then also part of our planning committee, because we're very, very committed to lung health, ICU, and sleep. And I think we can do it without having our respiratory therapy colleagues. We're also very fortunate that we have respiratory therapy students and trainee at different level in our ICUs. And I myself, and I was a resident, Pablo knows the story, would just sit with a respiratory therapist as a resident at USC, where I did the residency, and touch ventilator and be comfortable with the ventilator only because an amazing respiratory therapist was next to me and would allow me to touch the ventilator. And that's how I learned. And I tell this to my residents and fellows. So with that, again, truly fortunate and grateful for Pablo's expertise. And we hope to have more sessions like this. Please do visit our website, California Thoracic Society website, which has been, the website has been given on the chat. And we hope to have this recorded session there so you can learn. And we truly love education. We want to have this educational initiative to continue to happen more frequently. And I would also like to say thank you to our California Thoracic Society team, which includes Jason Seidler, Miss Vicky, Mr. Walter, and Mr. Dewbank, because without them, we wouldn't be able to do this session. So with that, thank you so very much for spending this Friday evening with us, and we will have more. And thank you again, Pablo.
You're welcome. Thank you, everyone.
Take care.